Dear my students, I would like to do this lecture face by face with you, but because of this pandemics of COVID-19, we have to do this in this format, sorry. So we will talk about the sudden painless visual loss and practical and diagnostic approach to such patients. I will just stop my video because it will cause a big file, so I have to stop it now here. I just want to say hi with my view first. So we will continue after this like that. I will describe some virtual patients and we will talk how to manage such patients one by one. So this is case one. The name is Hasan Saçaklı. The last names are giving some clues about the symptoms or about the diagnosis. So this is a 55-year-old male patient and he comes with a sudden loss of vision in the right eye with sudden millions of floaters just 2 days ago. And when you ask, there's no trauma, the medical history gives us that he has diabetes mellitus for 10 years and using oral antidiabetics, and the regulation is not bad as he says, and hypertension with, again, drugs, and he is a smoker. So this is a medical history. I will ask you first, do you have any other questions to make it clear about the diagnostic approach? You can ask, did you go to routine eye exams for diabetic retinopathy check? This is one of the most important one, because if he has already a diabetic retinopathy, then you can guess that this may be related to that diabetic retinopathy, this visual loss. Or you can ask if any previous ocular surgery, if he had any previous ocular surgery like cataract surgery, you can guess. This may give you a clue about, for example, posterior vitreous detachment, which may be induced with cataract surgery, and it may cause, vitreous hemorrhage, for example. Or any sign of photopsia before this, or you can ask about anticoagulant or antiaggregant use. So these are the additional questions you can ask in such a situation. Then we will start the ophthalmological examination, and you will start with visual acuity. Probably he will not be able to see any Snellen chart with the right eye, but he will see 0.9 to full vision in the left eye. So when he can't see anything from the Snellen chart, then you will start to show fingers from some distance, and he will be able to see just 10 centimeters, counting finger from 10 centimeters. Then you will continue with the anterior segment examination. You will have a look from the outside as a whole. You will look to the eyebrows, the globe as a whole, the eyelids, appearance of the eyelids. You will just check for any proptosis, any anophthalmos, or any ptosis, or ectropion, entropion, all those things first. Starting from the outside, going to the inner layers. Then you will check the conjunctiva, then the sclera, cornea, and the anterior chamber, and then iris, pupillary shapes in both eyes, and then you will look at the lens. So these are the things that you should look for the anterior segment examination. Then everything looks normal for this case. Then second, after that, the pupillary light reflexes should be checked, direct and indirect, and you should look for, is there any relative afferent pupillary defect, which is a sign of, optic nerve disease. And you will check for color vision, which can be checked with red object, any red object, or if you have an Ishihara test, it will be good. and you will check for ocular movements, cardinal ocular movements, which is important to check the third, fourth, and sixth cranial nerves. And you will do the cover and uncover tests and Hirschberg tests, which are important for strabismus. And you will check the intraocular pressure, at least with palpation with your fingers, which is a digital way of checking the intraocular pressure, at least in the emergency room, for example. And then you can continue with the fundus. So these are the basic examination methods for the ophthalmology. Then all of these were just normal, except from the visual acuity in the right eye, low visual acuity in the right eye. So all the other things were normal for this case. Let's continue with the fundus examination. When we look at the fundus, you will see this. What is this? I will ask, and you will say that, oh, we can't see anything from the fundus, so it looks just red, so probably it's vitreous hemorrhage. Yes, you're right. It's vitreous hemorrhage. You can barely see the optic nerve head, papilla, and some of the retinal vessels, but very roughly. So the diagnosis is vitreous hemorrhage, but what is the cause of vitreous hemorrhage? That's the main question. We should make a differential diagnosis at this point. So we know that patient is diabetic, hypertensive, smoker, and we don't know anything after this. So what can be the number one differential diagnosis for this case? It should be proliferative diabetic retinopathy. You should keep this in mind. For such a case, the first thing should be that. So to make a differential diagnosis for this, do you have any clue if it is because of the diabetes or not? We can have, if we check the fellow eye, the other eye, then if you have any retinal diabetic retinopathy in the fellow eye, then this diagnosis will be much stronger. Then, if you don't see anything in the fellow eye, just normal retinal findings, then forget about proliferative diabetic retinopathy for this case. If it is not a PDR, then you can think about as a complication of posterior vitreous detachment. As I told you before, this PVD may cause a retinal break or a vascular avulsion, which may lead to a vitreous hemorrhage. So this should be considered as the second option for differential diagnosis. And any other things? Yes, of course. Some other ischemic retinal vascular disorders, like a complication of ischemic retinal vein occlusion or a vasculitis or sickle cell anemia. So any other ischemic retinal vascular disorder which may lead to neovascularization in the retina may also end up with vitreous hemorrhage. So we should consider all these things. Since the patient had a basis for atherosclerosis, a very good hypertension, diabetes mellitus, smoker, so all these things add up to form a very good patient with, to form an ischemic basis, atherosclerosis. So these should be considered. Although this patient didn't have any trauma, we should ask for blunt trauma, and because this blunt trauma may cause induction of PVD, or it may cause iris root damage and leading to iridodialysis, and this will cause damage to iris blood vessels and may cause hyphema together with vitreous hemorrhage. So the trauma may also induce vitreous hemorrhage, just keep in mind. Any other thing, there are some other rare causes of vitreous hemorrhage, which is age-related macular degeneration. So this is, very common after age of 55 to 60. In the wet type or exudative type of age-related macular degeneration, we can see subretinal hemorrhage normally. But if it is a huge subretinal hemorrhage, it may open up to vitreous, ending up with vitreous hemorrhage from the choroidal neovascularization when it is severe. Another thing is ruptured retinal macroaneurysm. which is seen more in hypertensive patients. And a very rare case, in very rare case, we can see Terson syndrome, which is a vitreous hemorrhage secondary to subarachnoid hemorrhage. It regurgitates from the optic nerve head through the optic nerve head to the vitreous cavity. And another cause may be choroidal malignant melanoma or other tumors. If they are too big, that choroidal mass, the blood vessels of that mass may cause some vitreous hemorrhage. So what we should do? We should first do an ultrasonography to check if it is just a vitreous hemorrhage like this, or if there is any retinal detachment associated with it. So if we have a retinal detachment, we have to do an operation as soon as possible. Or it may be associated with a choroidal mass. This is a typical mushroom-shaped choroidal malignant melanoma. So all of these things will lead you some different approaches. So you may need to annihilate this eye, you may need to operate this eye with vitrectomy as soon as possible, but you may just wait for spontaneous resolution for this case. So they are all different. So coming to the management, if there is some diabetic retinopathy, like in this case, in the fellow eye, in the left eye, so the etiology must be diabetic retinopathy in the etiology of the vitreous hemorrhage must be diabetic retinopathy in the right eye. So if there is no directional retinal detachment in ultrasonography, then in such a case, we will just follow the case conservatively every 2 weeks. And we can say that please sit just erect, or you can use 2 or 3 pillows during sleeping, so that the vitreous hemorrhage may go down, sit down a little bit, so that the vision may be clearer, a bit better within weeks. So we can wait for spontaneous resorption, and if we can see some resorption 2 weeks later, for example, we start to do some argon laser photocoagulation to the clear parts. And every 2 weeks we see the patients and we add more laser. The main aim is to do laser to the ischemic areas so that the neovascularizations can be regressed, and then you don't have any additional vitreous hemorrhage. If there's no resorption within a month, then we have to do pars plana vitrectomy and laser photocoagulation during the vitrectomy. So this is the laser applied to the peripheral retina. This is the fresh laser burns, and this is the late atrophied and pigmented scarred laser burns. So we just spare the central macular area and we just do the laser photocoagulation to the other areas. So this is the main aim for such diseases like proliferative diabetic retinopathy. So how about if the fellow eye is totally normal? So this is the second scenario. When we look at the fellow eye, it's totally normal. So what can be the cause of the hemorrhage? So it's probably the PVD, which leads to this vitreous hemorrhage. PVD may be posterior vitreous detachment, maybe because of a retinal break, as you see here, and it may rupture a retinal blood vessel crossing the retinal break, like in this here, or it may be just because of the retinal avulsion without any retinal break. So these two things make an important difference. If it is because of the retinal break, a retinal detachment may follow within weeks. So we have to be very careful. So we will, of course, do again an ultrasonography. If there's a retinal detachment in ultrasonography, we will continue with vitrectomy, definitely. But if there's no retinal detachment in ultrasonography, we will just follow up the case. But we will see every week, not every 2 weeks, but more closely, because we can have retinal detachment, you know. So every week we will check If we can see the retina a little bit more with the spontaneous resorption, and if we can see a retinal break, then we should do laser. Like in this case, we should do laser. This was lasered before you see the scarred laser burns. Then when the vitreous hemorrhage goes away a little bit more, then we see the second break. And then we did a laser more. You see the fresh laser burns. So when the vitreous hemorrhage resolves spontaneously within time, we should check the periphery of the retina to see if there is any retinal break, and we should do this till all the blood has gone. Okay, so otherwise you can have some additional retinal breaks which may lead to retinal detachment. If there's no resorption within a month, then or if we see a retinal detachment with the ultrasonography in any of the follow-up visits, we have to do vitrectomy, surgery, and do whatever needed. So this is the main approach. I hope you got it. And then this is a very similar case, very similar to the one that I described, but he also had some hyphema, as you see here, hyphema, and we started vitrectomy. It didn't clear and spontaneously, so we first washed the anterior segment, as you see here, anterior chamber, and then as you see here, vitreous hemorrhage is being cleared with vitrectomy. With time, you will see that when it's more clear, you will see that there are some empty white blood vessels, ghost vessels. We call them as ghost vessels. But as you see here, these vessels are totally normal, just red blood vessels. These are ghost, and these are normal blood vessels. And what is this? This is, you can guess, I'm giving you some time. This is a sequela of a retinal vein occlusion, a branch retinal vein occlusion. So this is a late sequela of this, so we have to do laser. At the beginning, what you have seen is that this was the hyphema caused by rubeosis iridis, which is the neovascularization in iris, secondary to ischemic retinal problem. So that was done. Now we are leaving the first case, Hasan Saçaklı, to Hasan Yamuk. This is the second case. He is again the same person, actually, a 55 years old male, sudden loss of vision in the right eye, but he says that I have a deformed vision. He is describing metamorphopsia. He says that it started 2 days ago and it's more in superior visual field. I see everything deformed. The lines are like cracked and wavy. So, no trauma history. Again, medical history is important for diabetes and hypertension, and he's a smoker. So when we look at the ophthalmic examination, vision is better, like 0.2 in the right eye. The fellow eye is totally normal, and all the other examination findings are normal till fundus. And when we look at the fundus, if I were with you together in the class, face by face, I would ask you to describe what you see in this picture. And if I ask you to describe what you see in this picture, I will give you some clues to describe such a picture. You should first say that this is a fundus picture of the right eye. Because, you know, this is optic nerve, this is the macula, temporal to optic nerve. And you will start with the optic nerve head. If the borders are seen clearly, yes, it is seen clearly here. And then you should describe the vessels, retinal vessels, if they are okay or not. Then you should go to the macular area, describe the macular area if it is affected, and then you should describe the rest of the retina. So with this clue, you should say that if I ask you, this is a well illuminated right eye from this picture, and this is the optic nerve head. The borders are clearly seen. the superior retinal arcuate vessels look quite well, but the inferior retinal blood vessels are not so good. After one point, I can't follow them very well, and there are some retinal hemorrhages. Some of them are affecting the macular area also. These hemorrhages lie mostly in the inferotemporal area, not in the nasal part, not in the superior part. And I also see some white areas in this area. So this is what you should describe. And we will ask you in the examinations, please describe this lesion. So you should describe it like this. And when you look at the fluorescein angiography, you can see that in these areas, the normal capillary staining is like this in the angiography, but here, as you see here, it's like, you know, empty areas in the branches of main retinal blood vessels. So these are very typical of ischemia. This is the normal capillary staining, but as you see here, there's no capillaries here. So it's the ischemic areas, capillary loss areas. So this is very typical of what this is a retinal branch vein occlusion. You can see the retinal vessels, the vein. Here you can follow it. The normal retinal vein is staining like this, but here it's more, the fluorescein is much more in this blocked retinal vein. And when you look at the OCT in the superior part, the retinal layers are quite nice, but in the inferior part, as you see here, there is some edema of the retina. And this is inferior temporal branch retinal vein occlusion. And when we give intravitreal ranibizumab, which is an anti-VEGF injection to the case, after the first month, the visual acuity improves to 0.9 from 0.2 to 0.9. And as you see here, most of the retinal hemorrhages has gone, and the white parts are also lost, but the ischemia stays like that. The edema has gone. So we should do laser also to the ischemic parts of this case, just to prevent a later occurrence of neovascularization secondary to vascular endothelial growth factor secretion from these ischemic areas, and those neovascularization may lead to vitreous hemorrhage, like in the previous video that I have shown to you. Of course, we have to continue with anti-VEGF injections more as needed, but I will just emphasize one more thing. You see these white areas, what do you think they are? I would ask this if we were face to face. These are the soft exudates. These are called soft exudates, which are the indications, or which are the sign of ischemia, actually. With ischemia, we see these white areas. This is the sign of ischemia, intracellular edema. So let's continue. This is another case with superior retinal branch vein occlusion. So this case would come to you with, again, wavy vision, because the problem affects the macula also, and he will say that the inferior view is more disturbed, as you can understand. This is superior. And in this case, there was again edema in the superior part, no edema in the inferior part. After anti-VEGF injection, the foveal contour has formed, the edema has resolved. So now we have learned that when you have an acute vision loss, acute painless vision loss, number first was the vitreous hemorrhage, number second was the branch retinal vein occlusion, and now we're coming to the third one. This is Mr. Hasan Bulanık. Again, the same patient, he says, I have sudden vision loss 2 days ago. Everything looks blurred, and everything is blurred. And the same medical history, he has 0.3 vision, the fellow eye is okay. The other examination findings are okay. And now this is the fundus appearance of his left eye. So what do we see here? Again, it's a well illuminated left eye color fundus photography, but when we look at the optic nerve head, the borders are all edematous, and the optic nerve head is hyperemic, very hyperemic, and the blood vessels are tortuous, and they are tortuous and wavy. Maybe vascular dilatation is there also, and there are retinal hemorrhages everywhere. These are retinal hemorrhages because these are dot-like, some stain-like hemorrhages. So these are retinal hemorrhages. So what is the cause of this problem? When we look at the vein artery ratio, it's normally artery is 2, vein is 3, 2 to 3 the ratio, but here it's like 1 to 3. So the veins are dilated too much. So what may be the cause of this problem? It is central retinal vein occlusion. So it is, the previous one was just a branch vein occlusion. This is central retinal vein occlusion. The optic nerve head is edematous because everywhere is edematous. So what we have done is intravitreal anti-VEGF treatment, as we have seen here. You can see the optic nerve head leakage in the fluorescein angiography and macular edema in the OCT. And after the anti-VEGF injection, most of the hemorrhage has gone and the edema has gone, visual acuity has increased, and in the angiography there is no leakage. The vessel diameters are almost coming to normal size. So we have another option for treatment, which is intravitreal steroids. We use intravitreal dexamethasone implants for the same purpose. As you see here, there was edema. After the implant, the vision improves from 0.5 to 0.3, but within 3-4 months, the vision may decrease again and edema may recur, so you need another additional implant. Additional to dexamethasone. So we come to the fourth case, which is Mr. Muzaffer Hepten. This was a 65-year-old male. He came to us with, again, sudden total painless vision loss in the right eye, just 2 hours after the coronary angiography. It was all in a sudden. It was like turning the lights off. So no trauma. The medical history was important for, as you understand, the coronary artery disease, hypertension. He's a smoker and he has hypercholesterolemia. And when we look at the ophthalmic examination, the vision in the right eye is just perception of light, nothing more. And the left eye is quite good, like 0.9 or full vision. And we have now relative afferent pupillary defect in the affected eye. We can't check the color vision because the vision is just light perception. All the others are okay till fundus. When we look at the fundus, I would ask, what do you see? You would say that this is a right eye fundus picture. The borders of the optic nerve are not clearly seen, maybe some edema, and there is venous dilatation, and some of the vessels are not continuous. There is some, you see, stops of the blood columns. It's called kettle tracking. You see, it's not continuous. There's nothing here, then it continues. A stop here, then it continues. So this is a real different thing than you have seen before. And another thing is there's a red spot in the center, and around it, the retina is very white. It's much whiter than the periphery. So what is the cause of this? I would ask you, and you will say that this is central retinal artery occlusion, and this red spot is called cherry red spot or Japanese flag sign. Why do you think it is like this? It's because of hypoxia. When you have a central retinal artery occlusion like this, or any arterial occlusion which causes hypoxia, it will cause transaxonal, it will cause stopping of transaxonal transport of organelles in the axons of ganglion cells, and this will lead to intracellular edema. And this edema blocks the choroidal redness, so that retina becomes white. But in the central part, since there is no ganglion cells, you see that cherry red spot because this is just choroidal redness. There's no ganglion cell, there's no axons here. That's why it preserves its normal redness, but these parts are more white. And you know that the ganglion cell layer is more than one layer in the macular area. That's why it's more white in the macular area, but not in the peripheral areas. This is very typical. It's the same pathogenesis is again for the soft exudates that you have seen in the ischemic branch retinal vein occlusions or other ischemic retinal diseases. Same patients, and I would also like to emphasize that this is probably secondary to the emboli of the central retinal artery. The emboli probably is mobilized during the coronary artery catheterization. It mobilized a cholesterol plaque, and it comes and blocks the central retinal artery. And same patients. Now, this is Muzaffer Yerimelma. Again, the same patient. He says that within hours after coronary angiography, he can't see the superior visual field. It appears again all in a sudden. Again, the same patient with hypertension, smoking cigarettes, hypercholesterolemia, etc. So the visual acuity was 0.1, and because he can see it from the inferior visual field. And now we can check the color vision, which is defective, and there is relative afferent pupillary defect in the right eye. So you remember the previous patient also had a relative afferent pupillary defect. When I ask you, when do you see a relative afferent pupillary defect, you will say that it's common for the optic nerve disease. Do you think the previous case was optic nerve disease? For this case, no, it's not. So why do you think we had relative afferent pupillary defect? Can you guess? I can hear that you will say that since the ganglion cells, axons, form the optic nerve head, optic nerve, when the ganglion cells are damaged, it equals to optic nerve head damage. So it's just the same thing, you can understand. Again, when coming to this case, again, afferent pupillary defect and color vision defect. And when we look at the fundus picture, you see that in the superior part, this is a color picture of the case, right eye. The optic nerve head borders are quite nice, but I can't see the borders in the inferior part. Again, there is a white area in the inferior part, but the superior part is almost totally normal. Almost a half cherry red spot has formed. And when we look at the angiography, it gives some other clues also. As you see, the superior part is normally seen, the normally vascularized, but the inferior part, you see the blood vessels are empty. So since the artery is blocked. The fluorescein cannot go through the inferior retinal blood vessels. So what is the diagnosis for this case? This was inferior hemispheric branch retinal artery occlusion. This is another case. This is the superior hemispheric retinal artery occlusion. So you see the white parts. This is normal area. This is another central retinal artery occlusion, but you see that a small part is preserved, spared. Why do you think it is so? It's an anatomical variation, actually. There is a cilioretinal artery in 10 to 15% of patients, which supplies this papillomacular bundle area, a small area between optic nerve and the macula, which is a separate branch of ophthalmic artery. And when you have a central retinal artery occlusion, that part is spared. So this is an anatomical variation. It's not so important, but this is again another type of central retinal artery occlusion. So how do we behave in such cases? The first thing in retinal artery occlusion, either central retinal artery or hemispheric or a branch artery occlusion, we have to rule out the temporal arteritis. This is a rare cause of retinal artery occlusion, but it's very important. We should check the sedimentation rate and C-reactive protein rate. These are important. If they are high, we should ask for other signs of temporal arteritis. We should rule out this diagnosis because although we can't do any effective treatment for the affected eye, if we can detect that there is temporal arteritis, the fellow eye will be affected within weeks. And if we start steroid for such a case, we can prevent the formation of those. We can prevent the formation of the same problem in the fellow eye. So we can prevent the visual loss in the fellow eye by starting the steroids. So this is very important. But we don't have any effective treatment for the affected eye. We can suggest some hyperbaric oxygen treatments, or perfusion pressures can be increased with IOP lowering treatments, maybe a little bit, but visual loss is usually permanent. That edema will go away within 2 weeks. Retina will almost look almost normal, but only the arteries will be thinner, but the patient will not gain vision after that. So it will stay like that. So another case is Mrs. Ayten Ayrık. She is a 50-year-old woman and she comes with sudden loss of vision in the left eye 3 days ago. Her history is like that. She says that I had flashes of light and flying flies just 2 to 3 weeks before. I thought it will go away spontaneous, so I didn't go to the doctor. But then a black curtain started to come from one side of my view, and now today my view is totally gone. So what she is telling to you, I'm almost hearing your voice that this is very typical for rhegmatogenous retinal detachment. And when we look at the medical history of the case, he says that, oh, my doctor, I had very high myopia. It was like 16 to 17 dioptries. I've gone to a doctor to get rid of my myopia with laser. They said it's not possible with laser, but we can put an intraocular lens into your eye by doing cataract surgery, and then you can get rid of that eye myopia. And they did 2 years ago. And I was so happy because I didn't wear so big glasses, so high dioptry glasses. So I was so happy since this problem. So now what she says is that I have two more predisposing conditions like eye myopia and cataract surgery, which may induce the posterior vitreous detachment. So when we look at the ophthalmologic examination, she could count finger only from 1 meter, and the other ophthalmologic examination was normal. And when we look at the picture, this was the retinal detachments with some PVR in this area. Then we did vitrectomy and gas operation. After resorption of gas, she had a visual acuity of 0.8 at the end of the surgery, but she was very happy. But I just want you to want your attention to this area. What do you see here? This is optic nerve area, but there is a white part around it. What is that? Please try to estimate. This is related to the pathological myopia. This is called posterior staphyloma area. Why it is white? Because you can just see the sclera actually here from inside. Why do you see sclera? Because the retinal pigment epithelium and choroid is tint in this pathologic myopia case because their eye balls are very big, and when it becomes bigger and bigger, every layer is tint, and since it's tint in some parts, they become totally atrophic. So in the peripapillary area, it's totally gone. So this is related to pathological myopia. And we can see such appearances in pathological degenerative myopia cases, and we call them as posterior staphyloma. As you see here, this is a unilateral posterior staphyloma. You can see from the imaging that the anteroposterior diameter increases a lot, and all the layers are tint, and when it affects the macular area, as you see here, this is the optic nerve, this is probably the macular area. Some parts are tint, some parts are all totally atrophied, so these patients may see just 0.1. Sometimes if it totally affects the macular area, just counting fingers level, and it cannot be cured. But it doesn't appear, suddenly. It usually appear within years. So they become used to it usually. And as you see here, even the choroidal, you see those very thick choroidal vessels, very different from the retinal vessels. They can be seen very, easily through the retina. Normally, we can't see these choroidal vessels, but since the layers are tint, the retina and retina pigment epithelium, we can see those choroidal vessels easily, which looks like a tiger skin. So that's why we call it the tiger retina appearance. So this is the pathological myopia appearance. So when we come to the case 7, which is Seyfettin Sinirli. He is a 65-year-old male. He is here for sudden loss of vision in the left eye 10 days ago. He says that I cannot see lower half of visual field. So now, just by saying this, I can't see the lower half of the visual field. Can you guess what can it be? Till now, I can hear your voice that you will say that there should be a problem in the upper retina, which may be an superior retinal detachment or superior branch retinal vein occlusion or superior retinal artery branch occlusion. So I can hear that. That's very good. And then the medical history is important for diabetes, hypertension, smoker, hypercholesterolemia. Then when we continue with the examination, the left eye can see only 0.1 vision. The fellow eye is quite good. And there's also relative apparent pupillary defect in the left eye, and also the the color vision is defective in the left eye. So now, can you eliminate some of those that you have already described in a little bit ago? I think you can, because since he had pupillary defect or RAPD, then you can say that this cannot be retinal detachment, for example. This cannot be vein occlusion if it is not an ischemic one. So an artery occlusion or an optic nerve disease. You remember color vision defect and pupillary relative afferent pupillary defect may occur in optic nerve disease. Then let's continue with the fundus. When you look at the fundus, you see there is edema of the optic nerve head. You see the borders are wavy, blurry. You can't see the borders very well, but the retinal blood vessels, macula, and all the other retina looks quite nice. And the optic nerve head also is hyperemic, as you see here. Even the cupping area is not seen. And when we look at the fluorescein angiography, you can see leakage through the optic nerve head, which is very typical. But I would like you to pay attention to the inferior part of the optic nerve head, which is not leaking too much. Actually, the superior part has stained, not the inferior part. And when you look at the color picture also, the superior parts are more edematous, but the inferior part is preserved a bit better. So that's why he says that he can't see the inferior retina, but he can see it from the superior part. That's why. And this is called an anterior ischemic optic neuropathy. And this is secondary to occlusion of the short posterior ciliary arteries, which are the arteries supplying the optic nerve head. Actually, these short posterior ciliary arteries are coming from the ophthalmic artery, and it divides into two, superior and inferior branches first, and then each branch divides into 4 to 5 branches and circling all over the optic nerve head and supplying the optic nerve head. And when it is occluded, usually just the superior or the inferior branch is occluded. That's why it causes just the inferior or superior part more. But if you don't ask this again and again to the patients, they cannot describe if it is in the superior or inferior. They say that it's just blurry. So when you look at the optic nerve, you can clearly understand. Within time, within months, this edema will go away, this hyperemia will go away, but a pale optic nerve head will remain. The visual acuity does not come, unfortunately, almost at the same level. And what we should do for management is we should, of course, again, check for sedimentation rate and CRP rate to rule out the temporal arteritis, because again, like central retinal artery occlusion, short posterior ciliary arteries can be occluded by temporal arteritis. And there is no effective treatment. We can just start anti-aggregant treatments like aspirin for prophylaxis of the fellow eye, for example, or the other parts of the body. And coming to the last case, which is Müzeyyen Okumaz. She is a 75-year-old female. She comes with sudden loss of vision in the left eye for 10 days. She says that everything is wavy and she cannot see the central part. And there's no trauma history, and medical history is important for a smoker, a previous smoker, and he has some hypertension which is under control. But she says that, oh, my doctor, my mother had the similar problem at old ages. She couldn't recognize us without our voice, and she couldn't read anything. I'm so afraid that I will not be able to read because I love to read. That's why the last name is Okumaz, actually just the reverse. She loves to read, but she's afraid of not being able to read. So what this medical history says us is that this is a genetic disease, which is age-related macular degeneration. And age-related macular degeneration occurs after age of 55, and it's more in smokers, maybe a little bit in patients with hypertension. When we look at the ophthalmic examination, her vision it has dropped to 0.05 in the left eye. It was 0.8 in the right eye, so she didn't realize that there's any problem in the right eye, but there is some, you will see. And all the other examinations are okay till fundus. When we look at the fundus, please look at this. This is the right eye with 0.8 vision, and this is the left eye with 0.05 vision. And what we see here is that in the left eye, you can see that it's the color picture of the left eye, optic nerve head, and the retinal vessels looks quite fine. There is a hemorrhage under the retina, a subretinal hemorrhage in the macular area, blocking the macula, and that's why she says that I can't see in the central part. You see in the periphery, she can see a little bit, but in the central part is totally blocked. And when we look at the right eye, you can see some cream-colored dots in the macular area mostly. And when we look at the OCT of this eye, you see some wavy appearance, some accumulations at the level of retinal pigment epithelium, which are called drusen, which is a sign of dry type of age-related macular degeneration, ARMD. It's a dry type. It doesn't cause too much problem at this age. They usually do not feel that there's any problem in the right eye. It usually doesn't cause significant vision loss. Some atrophy will appear within years if it stays like this, as dry type. Vision may deteriorate very, very slowly, but it doesn't cause sudden vision loss. But when it converts to exudative or wet type of age-related macular degeneration, it may cause hemorrhages and sudden vision loss. And when you look at the OCT, as you see, there's subretinal hemorrhage and edema in the OCT. Just to let you see again, subretinal hemorrhage and edema of the left retina. And we have started the anti-VEGF treatments. That hemorrhage starts to resorb, and when you see it's dehemoglobinized hemorrhage scarring, and with the anti-VEGF, vision improves to 0.6, 0.7, and hemorrhage clears with anti-VEGF treatment. And with 4-year follow-up, vision improves to 0.9, and after 35 anti-VEGF Lucentis or ranibizumab injections, it's like this, but we still continue injections for this case. If we didn't do the injections for this case, as you see here, it will end up with a bad fibrotic scarring in the macular area, and it will continue to progress. And you see some hemorrhages. It's still growing. It will grow more and more within time, and it will leave a scarred tissue in the OCT. And this is the simulation of the central vision for such cases if you don't treat. The central view is totally blocked, and the peripheral vision is very disturbed. So they will lose their vision. So I will just show you a case of subretinal hemorrhage, massive subretinal hemorrhage secondary to age-related macular degeneration, but this was an anticoagulant user patient, so hemorrhage was very severe. which opened up into the vitreous cavity, as I told you at the beginning of this lecture. And what we do for these cases is we can, if we don't do anything, they can't see anything. Even the light perception may be lost. But if we can do a vitrectomy surgery, as you will see here, then we can preserve some vision, but it's a very, very demanding surgery, I should say. We do vitrectomy and do 360 retinotomy, and we open the subretinal area, take all these subretinal hematomas. As you see here, we are just cutting the retina to take the subretinal blood clots out, as you see here. And after clearing of all the hematomas, you see this is the normal color of the retina. We take the temporal retina to the nasal area. This is the macular area. You see it's a naked fovea because there's no retinal pigment epithelium there. If we just close the retina, then he can't see anything from the central. But if we prepare a graft from a healthy retinal pigment epithelium area and put it in the macular area, this is a choroid and retinal pigment epithelial graft. You shouldn't even touch to the retinal pigment epithelium in the central part because you will lose the retinal pigment epithelium. It's a very gentle procedure. So when you put it, then the retina should be put over the graft, and then you have to put silicone oil, of course, as a tamponade, and then should do the laser 360. And this is the post-op appearance. And you see the double layer of choroid, and the central fovea looks quite fine. And the graft is vascularized very nicely. And now this patient can see 0.5, and he can now read with this eye. So it is a demanding and like 3-4 hour surgery, and it has many, the risk of many complications, but it's the only chance for such cases. So I would like to thank you for listening my lecture, and I hope to meet you in better health days for your pandemia. And if you want to see more videos and more information about retinal disease, please visit my website, this website. Thank you and have a nice day.